Hello, I'm Mallie Schansfeld, Managing Editor for Medmark Media Publications. Welcome to an educational discussion and question and answer with Dr. David E. McCarty and Dr. Steve Carstensen. In our webinar today, we will discuss how an approach grounded in clinical excellence and continuity can drive both practice growth and improve patient outcomes. Associated with this presentation is a free CE quiz. At the end of the webinar, we will email all registrants the presentation recording along with instructions on how to access the CE quiz. Before we get started, I'd like to invite everyone to use the question and answer feature in the control panel to ask any questions, and they will be answered at the end of the session as time permits. Now I'm pleased to introduce our speakers. David E. McCarty is a board-certified sleep medicine clinician and a patient-centered care educator and advocate. He is the co-creator with Dr. Ellen Stothard of the Empowered Sleep Apnea Project, a cross-platform educational endeavor that embraces multiple platforms to teach about the complexity of decision-making in clinical sleep medicine, doing so with an unprecedented amount of creativity and fun, because, as we'll see in this presentation, cartooning is part of his platform. He's also the Chief Medical Officer of Rebus Health, an innovative cross-pollinating clinical ecosystem that allows clinicians and patients to co-discover the complexity of their sleep-wake issues to find a better and an individual plan towards healing. Steve Carstensen has treated sleep apnea and snoring in Bellevue, Washington since 1998. He's the consultant to the ADA for sleep-related breathing disorders and heads the ADA's Children Airway Initiative. He trained at UCLA's mini residency in dental sleep medicine and is a diplomate of the American Board of Dental Sleep Medicine. He lectures internationally and directs sleep education at the Pankey Institute, in addition to advising several breathing and sleep-related manufacturers. In 2014, he helped found Dental Sleep Practice magazine, and currently serves as chief dental editor. He has written chapters for several related textbooks. In 2019, a clinician's handbook for dental sleep medicine, written with a co-author, was released, with a second edition published by Quintessence, available now. The AADSM awarded him the 2023 Distinguished Service Award. Thank you so much for joining us, Drs. McCarty and Carstensen. Now I turn it over to you to learn more about our topic for today.
So the name of this talk is Driving Practice Growth Through Exceptional Clinical Care, and it's by Steve Carstensen and David E. McCarty. So here we go. Here's our disclaimers. We're talking about stuff that we have gleaned clinically, right, Steve? Right. So SomnoMed disavows everything we say. And I will also say that my project is really about empowered problem solving between providers and patients. So if you see a product mentioned in this, it's not that this is the one endorsed by Empowered Sleep Apnea. It's that we're talking about the problem solving process itself. And this presentation is intended for educational purposes only. Always refer to the instructions for use provided with any product mentions for complete information, indications, contraindications, and proper use. Our objectives. You want to go through these, Steve?
Sure. We're going to tell you some clinical factors in selecting kind of what is the right therapy for the right patient, the one in your chair. Learn how to strengthen collaboration between physicians and sleep labs and dentists and other healthcare providers. Integrate follow-up and coaching into your workflow. It's not just about one thing. Review approaching therapy through patient-centered co-managed care, dear to my heart, and highlight how personalized provider-led outcomes outperforms one-size-fits-all direct-to-consumer approaches.
I think that's what this is about, is we're talking about a common language in this talk, and it's how does the professional curate this incredibly complex subject matter for their patients so we all can find our way a little bit better than someone just pushing a button and getting something out of a vending machine. Yeah. We're going to do this. So those are our objectives. Here's our plan. So we're going to take you through a fictional case. We're going to meet Kate. I'm going to introduce you to the concept of the Empowered Sleep Apnea Project, which is welcoming you to my fictional island. That'll lead us to the 5 reasons to treat, which is the structure that we use to deconstruct this complexity between provider and patient, and actually between provider and provider. This is about eliminating silos. And I didn't mention this, but the Empowered Sleep Apnea Project is really about finding the fun in this complexity. And to do that, I'm a cartoonist. That was my cure for my own ADHD as a kid, as I drew cartoons all over my homework, and it's the way I think about things. But the cartoons are a fun way to get into this complexity. So I'm going to introduce you to that. And along the way, Steve and I are going to have hopefully some good clinical conversations. So here it's Kate. She's in your dental chair there, Steve. Chair number 1. She's 26 years old. She's new to your dental practice. She's had a 4 bicuspid extraction for orthodontic management of malocclusion when she was a kid. And she's got a piece of paper in her hand. And it says that it's a home sleep apnea test, and it has these numbers on it. And she says, you know, my primary care doc told me I don't have to worry about this. And I heard that dentists know something about sleep and breathing. And, you know, I'm sitting here in your chair, and this is a nice office. And what do you think?
I know some of you dentists out there are seeing that four bicuspid extraction and thinking, okay, there's the most important piece on this of information on the screen. We're going to teach you today that there's a lot more to this than just something as simple as that.
For sure, for sure. But this is a common scenario, right?
It is, yeah.
And these numbers come up, and we're left in the position of trying to decide what to tell people. And now we've got a physician out there who's telling her not to worry about it. And so now we're getting into well, why would they say that? And what does this mean? And so we're in the position of having to dispense some advice. So as we're thinking about this quotation came up. If I had an hour to solve a problem and my life depended on the solution, I would spend the first 55 minutes determining the proper question to ask and solve the problem in less than 5 minutes. So everybody says, Einstein says that. That's probably not true. But the point is here, we're going to take this apart before we say, do they need an oral appliance? Because that's the real question. But that's a big question that requires a long setup, and that's what this is about. And so if we're going to collaborate, we have to have a shared understanding of a complex terrain. And our clinicians must assist patients in the why. Why are we doing this before we start dispensing advice? So here's where I'm going to introduce you to our island. And if I can can anybody see my cursor? Does that show up?
It does.
Awesome. So we're going to be talking about a progression through a series of ideas. And it's the idea of teaching complexity is scary. And so most of the time people will simplify it into a small part of the complexity so that it maintains their intellectual safety. And often that will fragment the system. So this is an idea that we're going to introduce this with a patient-centered perspective. We're going to start here in the bay of narrative where we'll talk about why is this person even here and what's bothering them. And we're going to spend a lot of time in this structure. The 5 reasons, monument, and coffee hut. So this is the idea that there's 5 reasons to treat sleep apnea. And before we even talk about whether we're going to go over to treated territory, whether we're going to cross this decision river to get to treated territory, we really have to spend some quality time here. So it's going to get us into some significant questions. What is sleep apnea? There's so much to unpack there. So we're going to get to the root of that. How, in fact, is it diagnosed? Why should an individual patient even consider treatment? And how should we decide whether an oral appliance therapy might be the right thing for your patient? Anything to add to that, Steve?
It's the individual patient part is the key, because you have this structure in your head. And once you've been able to unpack the complexity and master the different steps along the way, now you don't have to think about that part anymore near as much as you need to think about the individual patient. And it becomes easier to perceive what is going to be the right combination of effort to make this outcome successful.
And that's something that we can't just keep in our head. We're going to have to find a way to share that with our patient because
Right.
they need to be a part of this decision. So it brings us to this very, very simple question. Not so simple. What is sleep apnea? I bet if you asked 10 different providers in different practice settings to explain to you what sleep apnea is, you might get 10 very different answers. What do you think, Steve?
Well, it depends on what area they see it from. The old
Right.
story of the elephant, right? And so we all see it from our different perspectives. And sleep apnea means one thing in one definition. And, what really matters is what's wrong with the patient.
Yeah, for sure, for sure. But if we're talking about this label, this thing walking around, hey, they told me I have, quote, sleep apnea, there's got to be a ground truth. So that's what this is to introduce everyone to. There actually is something that we have agreed as a group is ground truth. And when I say we, I'm talking about my tribe here. This is the AASM, the American Academy of Sleep Medicine. This is the medical side of thing. And the document where these diagnoses are kept is the International Classification of Sleep Disorders. So what I intend to do for this part is to kind of get into what this is, because understanding this diagnostic criteria means that we're going to have to start getting into some jargon, some terminology. And I think that if we're going to explain this definition to our patients, we need to understand the jargon so that we can help them understand the jargon, because that's what it takes to decode these weird metrics like the AHI. So let's get into it. This slide is to help us understand the jargon of events. So it turns out that when we're scoring sleep studies in the lab, there are several different kinds of breathing events that can happen. And the events are defined based on what happens with breathing effort versus airflow. So in a classic sleep study in the laboratory, there will be elastic bands that go around the chest and the belly. And when the person is trying to breathe, those bands will move, usually in a sort of a sinusoidal pattern like you see here. So if the person is trying to breathe and the airflow sensor, which is usually a little device that looks like an oxygen cannula under the nose, it's not dispensing oxygen though, it's measuring air going in and out of you. Okay, so if there is breathing effort, but there is no airflow, then that's called an apnea. Apnea means not breathing, okay? And it's an obstructive apnea if it looks like this, effort with no flow. Now a central apnea is a completely different phenomenon. That's where the effort itself stops. So while this is struggling against a closed airway, there's another word for that in English, by the way. It's called choking, right? So this is called struggling against a closed airway. This is sort of a pause in breathing that follows a heavy sigh. So there's different connotations to whether the events are obstructive versus central. Now you'll hear talk about a mixed apnea. All that means is that the person had a central apnea, and then when they started trying to breathe again, it was against a closed airway. So it means they have elements of both in that particular event. Now let's talk about hypopneas, because this is where most of the trouble starts with the misunderstanding. Don't you think, Steve?
Absolutely, because if you look up the definitions, this is where there's a lot of disagreement about how do you define this. And so some reports reported out very detailed, some ignore it completely. And when you talk to physicians, when I talk to my collaborating physicians about the importance of hypopneas, many of them just throw up their hands and go, well, it's part of the HI, you know.
And so it depends on how they were defined. And this is the evolution of this language is the issue, is that whether it's defined by the CMS criteria, which means that there's a 30% drop in airflow, which causes a subsequent 4% drop in O2, versus the newer AASM criteria, which is that it causes a drop in airflow, which leads to a 3% drop in O2 or an arousal from sleep. Now that's the real kicker. And this is because we've learned along the way that it's not just about the oxygen desaturations, that the sleep fragmenting characteristics of this problem are important. And so the AASM built it into the diagnosis. Now the RERA is the sort of leftover stepchild. The RERA, the respiratory effort related arousal, is an event that was actually conceived at this sort of sleep mothership out at Stanford. This is when we were realizing that there were people out there and they were having a fairly good clinical response to an intervention like CPAP, but they had no 4% or 3% problems. They only had arousals from sleep. And so Stanford put in this idea in our heads that, hey, the arousals might be important. So it turns out that you can still score RERAs. And the way you define them is it's just not meeting the criteria for a hypopnea. Maybe it's not quite a 30% drop in airflow, but we're still seeing that fluttering across the top of the airflow trace that's associated with snoring, and it causes an arousal from sleep. Now, here's the thing. To be accredited by the AASM, you don't have to score RERAs in your lab. I want you to keep that in mind. So 2 things on this chart. One thing is, first of all, it's hard to kind of tell obstructive hypopneas and central hypopneas apart. And for that reason, most labs kind of lump them together. And so you'll just see hypopneas generically reported. And when you're reading an apnea hypopnea index, keep that in the back of your mind. I wonder how many of those hypopneas might be centrals. Now down there at Seattle, that may not matter that much. But I'm telling you, up here in the mountains, the higher you go in the mountains, the more likely you are to have these kind of central oscillations in your breathing that have maybe something else to do with your sleep experience. Like maybe it's because you've got leg movements going on. So bottom line here, there's a lot to unpack with the AHI. Anything to add to that, Steve?
Well, yeah, Dave, there's, like you said, there's a lot to unpack because we could get into the brain's response to CO2 balance and the blood gases and differentials. But, you know, this audience, they don't need to hear all of this. So we have some other things to talk about, Dave. Let's keep moving.
Yes, but
you and I could talk about this a long time.
Plant the idea that the AHI needs some discussion, right? So let's get into the ICSD-3. This is it works that you can get to this diagnosis 2 ways, and I'm going to decode this for you. So it says diagnostic criteria A and B, or C plus D. So we're talking about the A and B right now. The A and B. A is the presence of one or more of the following, and that all just decodes to they've got something wrong with their sleep, right? They've got something that affects their sleep-wake experience. So it can be breath holding, gasping, choking, but if they really leave it open, it can be anything that leads to impaired sleep-related quality of life, okay? Or it's a bed partner observation, habitual snoring, breathing interruptions, okay?
And whatever gets them to the doctor saying something's wrong here.
Something's wrong. Yeah, what's wrong? But the other side of this is, though, is that we are pushing people to screen, which means that we might start to find things where the person didn't even have a complaint yet. So I want to be thinking about that side too. But you're right. It's what did they come there complaining about? And if their sleep study shows that they've got 5 obstructive events per hour or more, and they define their obstructive events as apneas, hypopneas, or RERAs, okay? So when you put it plainly, you only need 5 RERAs per hour on a sleep study, and RERAs are really, really easy to get. So it's not very hard to make this diagnosis. Now we're going to talk about the blue box in a couple of slides, but that's that you've done your due diligence and you don't think that these symptoms are caused by something else, right?
For example, a medication they're taking, or if they just decide not to sleep very long, you know,
exactly.
They could be sleeping in the daytime because they decide to go to bed at 1 and wake up at 4.
Because they think it's normal to drink 8 Red Bulls a day, and and to get 4 hours of sleep, right? So you have to sort of take a history. So we're going to get to, well, what does that history look like in a second? Right. So it was A and B or C plus D. So what's the C? So C is, well, you have 15 events per hour. That's it. So if you think about it, if I send everybody in this work group to a sleep lab and we really are diligent about scoring RERAs, I'll bet there's a number of us that are going to have 15 RERAs per hour, because RERAs aren't hard to get to. So that makes me sort of come to the conclusion that if we're going to come to widespread screening, we're going to start identifying disease that needs to be decoded before it's treated. Does that, do you resonate with that, Steve?
Sure. And that means the dentist sitting there also has to know how to read these sleep tests, how to dig into the details just a little bit. Don't just look at two numbers and think, okay, I've got this. Let's move on.
Yeah. It's not about the number. That's the number is a portal, and
Right.
it's definitely a doorway, but it's something that needs a lot of discussion. So this brings us to that blue box. So that blue box always seems like a throwaway. It's not better explained by blah, 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 blah. But it's like, yeah, we should roll out of this stuff, but there's a process. And I just want to put this out there that this is the other part of the Empowered Sleep Apnea project is a recognition that sleep-wake complaints, non-specific sleep-wake complaints, like I feel bad, I can't sleep, there's a process to getting structure to that. And the five-finger approach is based on a paper that I wrote back in 2010 when I was working at LSU, and it ended up in the five-finger approach mountain as the part of this Isle of Sleep Apnea journey. So we're not going to get into how to deploy this. That's a subject for another talk, but I've written extensively on that, and it's also a part of our podcast if anybody's interested. But that brings us to the subject of language. So because this term, upper airway resistance syndrome, is out there, I need to sort of talk about the fact that this has been officially retired by the American Academy of Sleep Medicine, and it's because of the AASM's attempts to unify this under one umbrella. And weirdly, ironically, that attempt to unify it under one umbrella has led to greater division in language because of the way the world is. Some labs choose to score RERAs, some don't. Some facilities, because of the way insurance payer requirements are, have chosen to only call it sleep apnea when it meets Medicare payment requirements, you see. And so patients end up getting confused with this language. So I put this slide up. This is a cut and paste directly from the book, just to sort of remind everybody that this language is loaded. And I believe that upper airway resistance syndrome has legs in the dental community because it's meaningful. It's a meaningful term, right, Steve?
It kind of gives us a label to put on a patient who has complaints, but yet has gone through a one-night sleep test somewhere and was pronounced to be, disease-free.
Yep. And so it's a place to put people. And on the other side of it, though, if we flesh out this definition to the full extent that it should really fluff up, and if all labs were really scoring RERAs, then what we call upper airway resistance syndrome in one context would be called RERA predominant obstructive sleep apnea in another context. Does that make sense?
It does, but that's not going to be. Let's move on and let's talk more about Kate.
Yeah, let's do it. So Kate, her home sleep apnea test showed an AASM or 3% AHI of 16 and a CMS AHI of 4 per hour. RERAs weren't scored, not uncommon. So the RDI would probably be higher than that AHI, but it wasn't reported. So the bottom line is, based on our current ground truth, she has G47.33, right, Steve?
Right. The obstructive sleep apnea label applies because she fits one of the criteria. Now, there are some
Yeah,
complications sometimes because just to throw an insurance company rock into our stream here is because some insurance companies don't recognize these AASM guidelines and they only recognize the CMS guidelines. And, we don't really have time to dig into why those two make different decisions, but that is a reality in the chair as well.
it's a reality. But the bottom line is the AASM says this person has sleep apnea. Their insurance company has chosen that they do not want to recognize this flavor of sleep apnea is what those insurance payer requirements mean. So the question is, what do we do, right? Yes, we can say, yes, Kate, you do have sleep apnea. It's like, yes, Virginia, there is a Santa Claus. You do have sleep apnea, but it doesn't get us anywhere because the label itself isn't something we can work with. So we have to get to someplace else. So the point here is that if we're going to go from untreated territory to treated territory, there's a lot of ways you can get there. And I don't believe it's right to just tell people, well, we only do things one way here, so here you go, and have them expect it. There was a company when I was a kid in California, I think it was for tires, but they said you can't choose the right tire if you don't have a choice. You know what I mean? And how can the patient choose the right experience if you don't give them choices and help them understand them? Steve?
See, we're there as experts in the treatment options. We can provide the different ways across the river here. We can talk to them about their how their life can go to address their issues, but only they can actually perform the treatment that does the change for them.
And only they know if it's working because only they know why they need it.
Right.
That's the hard part of complexity, is that the patient is in charge and you have to help them know how to be in charge.
So it's not like we lay out a CPAP here, an oral appliance there, and a nerve stimulator over on the other side, and we'll get to all those, and just say, okay, pick one.
Right. Like the Hunger Games, you got to run and grab.
That's right. Not like good. I like that one, Dave. No, it's not like that. It's just, but we're there for our expertise, but they're the experts on themselves, and so we have to work together here. And
Yeah.
engaging them with asking them, what are your thoughts about that? Is really quite important.
It's a little bit like being an expert, I don't know, sommelier or an expert waiter, is that we've got these different ways of satisfying your nourishing needs. I've got this and I've got this and I've got this, and I understand their characteristics. Let's find out a little bit about you to see what you might like, and let me help you decide. Does that feel right to you, Steve?
That's it exactly. That's the crux of it.
So let's talk about it. When I present these to patients, I'll usually just go through it. So Steve, how do you talk about CPAP with folks?
Well, first of all, I always say I love CPAPs because the CPAP does the best job that we have, the most predictable job, let's say it this way, of resolving those issues that you brought up on the wavy lines. If we want to stop the airflow from being halted, then we provide a CPAP or some one of the pressure devices. However, sadly, there's not that good of adherence to those devices. And so if they worked for everybody, that would be fantastic. It worked for my dad every night once he finally got into one. But it doesn't work for my brother because he doesn't feel any different. So he won't use it. So CPAPs are wonderful, but people won't use them. So we need another option. And the other option, go ahead.
I'm sorry, I'm just going to add, it's a physical treatment strategy, and if it's not right for everybody, right? And interestingly, also, I think this adds a new wrinkle. There's a new narrative that if the pressure on the CPAP is too high, it might actually be harmful. And so it alters a little bit the risk-benefit ratio of this intervention. So understanding that it is sort of the gold standard for getting those wavy lines to straighten out, but it comes at cost sometimes.
It does. So, and gold standard is, I hate that term, Dave.
I hate that term too. I hate that term, but it's culturally accepted as this is what we do. But that cultural acceptance also comes at a cost. So the oral appliance therapy, you presented CPAP. This is how I talk about oral appliance therapy with my patients from the medical side. This is a covered option. It's a traditional option. It's been around for a while, and it may be something that your insurance is going to pay for. The other thing is that we've got pretty good data that it does lower the AHI and it achieves some of the outcomes that we're interested in. So there's good peer-reviewed literature that it improves things like daytime sleepiness associated with sleep apnea. This also, because it's a physical treatment strategy, it translocates the jaw forward, right, during sleep, the jaw thrust maneuver. It comes at a physical cost sometimes. And so sometimes it can cause physical problems, and it doesn't always resolve all of the things that are important to the patient. So things like the AHI result may not completely resolve, snoring may not completely resolve. So it's one of these things that we have to weigh. Is this the right thing for this patient? Steve, would you add anything to what I tell my patients?
I would, because it does add some things that the CPAP can't do. For example, if you have a patient who has long worn a night guard to protect their teeth from grinding habits.
That's a great point.
Guess what? We get to do that with oral appliances. You can't do that with a CPAP.
And you can take it camping. Very meaningful to people in my part of the country, right?
In my part of the country, people go on trips all the time, to business trips to Asia and other places from here. And so they don't want to have to take something that has to plug in different, electrical environments.
I've even had some people in my clinic sort of understand that this is not a one-size-fits-all solution. So they use their CPAP when they're home and they take their oral appliance when they go backpacking.
It's good to have choices. And one of the choices we have is there's like 150 different appliances. And so we get to choose the appliance that matches the patient quite well.
Yeah.
And so there's a lot of characteristics to each one. We're not going to get into that. It's a whole another lecture. But when you get to a high quality devices, and the one on the screen is called Avant by SoundMed, if anybody's curious, that's actually one of our highest quality devices because it meets a lot of patient needs. And it gives us an opportunity to match the patient to the therapy, just like matching the right mask, for example, to a PAP therapy. Yeah.
And when we're talking about obstructive sleep apnea with the language of the Impaired Sleep Apnea Project, we use the language many moving parts. This doesn't happen for one reason. I'm trying to get away from the legend that, obstructive sleep apnea is blank and it's a floppy airway. And so basically that translates to CPAP deficiency. No, obstructive sleep apnea has many moving parts. And when we conceive of it that way, then that's the reason why we get into, well, I know different devices, because this one has more room for the tongue. And this one, they'll have different characteristics based on what you perceive to be this patient's individual flavor of sleep apnea. Do you have anything to add to that, Steve?
Well, the other line you have here is often covered by medical insurance. These days, it's very, very rare that they're not covevered.
There's that instance of Medicare only covering devices with a metal hinge. That's legendary. Is that still something you perceive as active?
Not quite metal hinge. There is one that's all nylon that's covered, but there are only 3 designs that are covered, and many iterations of those 3 designs.
So there are some constraints that are put on the device you choose, is what you're saying.
That's correct.
The payer. Yeah. Okay. Well, let's move on. We don't have to go into all of the risks, benefits, and alternatives in that much detail. But the point here is this is a big salad bar, and that there are many players that are adding to our understanding. And one of the newest players on the horizon is this expansive orthodontia narrative. Steve, would you like to talk about this?
Sure. What we're looking at here is the fact that breathing problems are really stemming from a structural issue along with function. Because if we have a poor bony support of the soft tissues that surround the upper airway, now we pinch the air through too small of a space, and that engenders some of the troubles that you see on the wavy lines. And so if we can expand that bony structure and allow a bigger air space, it makes physical sense that breathing should be easier. This is a relatively new way to address breathing problems, new in medical history. And so some of the studies are equivocal so far, but we're getting some very good science behind many of the ways we are doing this. And also, if we just consider the three-dimensional physics plus the function, it makes such empiric sense that we can't think of why a narrow airway is better than a bigger airway.
And the anecdotal evidence is starting to pile up too. The real world data is coming in.
Yeah. So there's a number of ways of doing this, and
sorry.
That's all right. There's a number of ways of doing this. We just have to be good doctors and choose the right way.
Yes, and that would include financial repercussions for the patient as well. So we want to try and find devices that do have some evidence behind them, if possible, and we want to think about the patient's individual anatomy and try and find the right device for them.
There you go.
Surgical options, I'm going to whip through these because
Yeah.
this is basically, there's so many things you can consider, but there are options for dealing with a problematic nasal airspace. And my Rebus ecosystem now, we consider ourselves to be a nasocentric practice. That's a verbiage I want to get out there because nasal breathing is just different from mouth breathing. So if they can't breathe through their nose, maybe you want to do something about that. If there is obstructive soft tissue anatomy, such as tonsils, base of tongue, so there can be lingual tonsils, there can be all kinds of things that could be removable. So is surgery a possibility there? Surgery to rearrange the bony constituents of the face. The craniofacial respiratory complex can be rebuilt. And that is almost always curative for this problem, but obviously that is a very, very large endeavor.
A big decision.
Big decision. Then there's the neuromuscular option. So hypoglossal nerve stimulators. We've got the intraoral muscle stimulation therapy. It's kind of the new kid on the block for mild and snoring. And we've got the idea that you can rehab these muscles. So, if you can rebuild your leg after you've broken your leg with PT, well, by gum, you can rebuild those muscles in the back of the throat too. And there's some fun things to do, like playing the didgeridoo and singing for snorers. Obviously, weight loss. This is now getting more attention because of all the biologic weight loss options. But weight loss, if that's indicated, you can tell them to just avoid the supine position. Some people, that's the only time they really have apnea is when they're on their backs. And if that's an orthopedic option for it, maybe that's all they need to do. What about this option? This is digging a little deep, but if someone is heavy into the substances, this is making this problem worse, right, Steve?
That's right. Yeah, I love what you said here. Disadvantages. Nobody wants to quit alcohol.
Right. But you mention it because, sometimes it takes a long time for people to make the right decision for themselves. And if we're all supporting them with the same language, sooner or later it might get through.
And your conversation with your patient about the importance of breathing and oxygen to the brain and whatever connects with their vision for their long-term health, that might be the trigger that they need.
Yeah.
So it's the comfortable, relatively intimate doctor-patient conversation that you might plant that seed that gives them that choice to be healthier.
Absolutely. It's a longitudinal relationship. Now, you will see oxygen being thrown at people with sleep apnea. And so because of that, I wanted to sort of show you when it might be an option. So relocating to a lower altitude is one option here where we live, because whatever's going on with your airway, the higher you go, the more likely you are to have a desaturation with it, and the more likely it is to cause problems. So going downhill sometimes helps. If they don't want to go downhill because leaving the Rocky Mountains is a bummer, then you can get them supplemental oxygen. So this is something we sometimes do up here, and it can stabilize that central apnea component of the sleep apnea. And then there's the idea that if you just get them posturally more healthy, this is a new idea for many of us, but opening the mouth changes both obstructive and central sleep apnea, right? You want to comment on that, Steve?
There are nerve signals that go from the nose to the part of the brain that controls breathing, the autonomic nervous system. There's nerve signals rely on temperature changes in your nose. And if you don't breathe through your nose, the part of your brain that's looking for a signal isn't getting one. And that means that there's a confusion in there. And that could be one of the reasons of central apnea. We don't know that yet.
But the other thing is when you open your mouth, you lose the vacuum of the oral vault that keeps that tongue forward and up. So as soon as that mouth opens up, that tongue gets lazy and it falls back. And then what happens during recovery breathing is these big, large volume mouth breaths. And what does that do usually? Well, it pushes that CO2 level down even further from those large volume recovery breaths with that mouth open. And then we see how an obstructive event can lead to a central event. So they're related, So this is why mouth taping for some people might be a really good idea.
Mm-hmm. Yeah. And sometimes we use that all the time. There's a number of ways to keep the mouth closed. We use that all the time to help form a good habit of nose breathing.
Mm-hmm,
Another
mm-hmm.
whole lecture we can get into, Dave.
For sure, for sure, for sure. And there's some new products out there too. These oral obturators that you can see advertised are little silicone devices that go in front of the teeth but behind the lips, and they can help prevent mouth breathing, but without the discomfort of the tape.
Right.
So whipping through some of these options, just knowing these are out there, that if the person has a hard time breathing through their nose and saying, yeah, that's me, I do open my mouth. Well, sometimes these nasal dilators can be just the ticket. Treating nasal allergies for the same reason, opening up that nasal airflow, getting people breathing through their nose to prevent that mouth breathing position can be part of this.
Super common to do that, and also to promote clean air in the bedroom, like a good air filter in the bedroom, because nose physiology changes while we sleep. That's a critical factor for a lot of families.
Yeah, yeah. Thinking about that, when would a dentist take an environmental or social history? Well, what's your bedroom like? Is there a cat sleeping on your pillow, during the day? That kind of thing can be very helpful to know.
Right.
So treating the whole person means that we have to understand why are we going to do this? And what I'm teaching my clinical ecosystem now is if we collectively, me and my patient, if we don't know why we're treating this, if we're treating it because you have sleep apnea, we're not going to know. We're not going to know if we got it right if we don't know why we're doing it. So this is our method of doing it. You get the patient to sort of weigh in. And I usually ask, are you satisfied with your sleep? And, if they're not being defensive, they'll usually tell you the truth and they'll say, well, no. And then you get them to weigh in. How dissatisfied? Because this opens up a doorway that's almost like the orthopedist saying, where does it put your finger where it hurts? Right, Steve?
Right. And the questions you have there are so powerful because they're what? Open-ended questions. That's getting your patient to tell the story. And that's really, really what you want to do, as long as you also emphasize the listening part of that.
Mm-hmm, mm-hmm. So it's not just, oh, it's a 6. Okay, checkbox filled, moving on. No,
Right.
6 out of 10 means that they failed themselves, right? On a standard academic, 70% is a passing score. So I pay attention to that and I actually feed that back to my patients. Wow, you gave yourself a 6? That's a D. Where did those points go? What's really hurting here? And then when they tell you, well, it's because I'm waking up all the time, and then they stop, that's when we start to explore what we know are the other 5 reasons to treat. And we get them to fill in those details. So, okay, so you're saying it's 6 out of 10 because you wake up every 20 minutes. I didn't hear anything about the daytime. Does that mean you're feeling fine then? Oh, no, 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 no. And you can kind of get them to extrapolate. So that 6 out of 10 for me is a critical doorway for me to help the patient establish what is their narrative. Anything to add to that, Steve?
No, I love that part because again, we use tools of listening to ask the next question, to help them uncover, to verbalize things that they don't really know how to say. They don't come in with a skill set for describing their sleep.
Yep.
That's up to us to help them find that. And the 5 reasons to treat is a fantastic way to give them a framework for telling the story.
Most people are surprised by the terminology sleep-wake complaints because it calls attention to the fact that there is always a shadow to whatever your sleep complaints are. There's a shadow on the other side of it. How does this manifest during the daytime too, during wakefulness? Getting people to think about it that way is important. All right, so risk is the most challenging of these reasons to discuss. And when I was really working my way through, how am I going to present this to people? As I told you, I think in cartoons. And so the concept of how do we talk about risk presented itself to me as an absurd concept that deserves exploration. So here's the doc, all meaning good intentions. I'm reading my reports, all the data say you should stand over here to modify your risk. It's to lower the risk of being over here. It's kind of like telling the person you should be on a CPAP machine. This is going to lower your risk. This spot is riskier. And then thanks, doc, says our buddy Claudio. So he's over there minding his own business, doing what the doctor told him. And then, pow, boom, just gets socked out of nowhere. And he says, what the, doc, what about lowering my risk? And here's the hard part about discussing this from the provider side. How do you explain what just happened? Like, he went home with a CPAP machine and had a heart attack anywhere. The CPAP machine abused him. What about my risk? And all we're left with is, well, you should see what would happen if you were over there. So it's a hard thing to talk about. So I realized that I was going to have to do this in a different way. So I went back to the person I perceive is probably the first super cartoonist in history. This is Hans Holbein the Younger, and he produced a series of woodcut cartoons that he called the Dance of Death. The idea was that the skeletal figure of death was this ultimate, it was the equalizer. Whether you were rich or poor, profane or pious, death will come for all of us. So it was a very humanizing series of woodcuts that we all have to sort of square off with this thing. So I use this as the idea for how we're going to present these 5 reasons to treat. So Hans Holbein, take it away. Let me introduce you to my little friend. Here we come, the 5 reasons to treat. The first one is risk. It's first because it's hardest to talk about. But sleep apnea can kill you. It can kill you younger, usually by cardiovascular disease, stroke, but cancer death is increased and all-cause mortality, meaning accidents too. So what kind of sleep apnea kills you? That's what we're going to be talking about. Other reason to treat, second, snoring. Sometimes you do, sometimes you don't, but sometimes it's a big deal. Third reason to treat is the sleep experience. It might be rocky, but it might not be. Fourth reason to treat is the wake experience. Are you impaired? Is the wake experience problematic? And the fifth reason to treat is comorbidities. That's a mouthful, but what it means is that the nonspecific stress, physiologic stress of not just fragmented sleep, but also the intermittent hypoxia and the transthoracic pressure shifts associated with obstructive events, these create other health problems and make them worse. So does the person have those problems, and do they need better attention? These collectively are known as the 5 reasons to treat. Yes, Steve, take it away.
Dave. Yeah, these give us such an easy framework. I've never said the words transthoracic pressure changes to a patient, but I can describe the expansion of the chest and negative pressure, and you can't breathe because your airway's closed.
That's right.
So this framework is so accessible for people,
and it helps. It helps with the getting past the feeling that someone is shoving something in your face and the illusion that someone's trying to sell you something. Right. And that's not an illusion sometimes. It really feels that way to our patients. And so this is a decision for them to ponder seriously about why they would want to do that. Right. So the first reason is the hardest topic to discuss because, as I said, sleep apnea, we know this medically, culturally. Like, how do you know anything? But culturally, this is something that's accepted as a truth, that sleep apnea can kill you and it can kill you young. So proving a condition actually kills you, like it's an incremental health risk is difficult, right? Think how long it took for the case to be made that cigarette smoking was a health hazard. There's a lot of also-rans that go along with sleep apnea, such as obesity and diabetes and hypertension. And how do you know it was the sleep apnea that did it to them? So the answer is, well, we have tools, man. And one of the most powerful tools is something called a population-based prospective observational trial, okay? A cohort study. And this is one of our biggest. It was this study was published in 2008, so the study began in 1990. It's the 18-year follow-up of the Wisconsin sleep cohort as stratified by AHI. Now, you're seeing here what we're seeing. If your AHI was less than 5, at 18 years, you had about a 97% chance of being alive. The higher the AHI goes, the lower your chance was of being on this side of the daisies at 18 years. So by the time you get to AHI above 30, the 18-year survival rate is 57%. And that's something that I think we all should sort of say, wow. But here's some things to keep in mind. Remember how we said we got to unpack the AHI. So the hypopneas here were defined by the 4% desaturation rule. And this was performed at sea level on people who were mostly in their early middle age. So in their 40s was where they started work. And their cardiovascular disease incidence was very, very low at the beginning. All of this translates to the things that make that central hypopnea phenotype kind of blossom weren't in this group yet. So cardiovascular disease and age and altitude are the 3 of the big ones that concentrate central apnea physiology. All this means is we have to think about what flavor of sleep apnea the person has too. Anything to add to that, Steve?
Well, also think about the time frame of this. Like you said, they started in 1990 or so, and it's probably even earlier than that. And by the time they got all the papers written, and so the science has moved on. We know more that people are heavier too, and so there's a lot of things going on that are different from the patient in the chair and the population that made up this sleep cohort. Yep. And if you use this and go, oh, if you don't treat your sleep apnea, you're going to die. That's a scary way of approaching it, and that's really not as helpful. I like this study because it does put weight on what we're trying to do. But honestly, I think it puts more weight in my head than it does in my patients. I look at this and go, my job, my role, my mission is to help my patients avoid that 68%, move them up the scale some. It's not to use this to motivate them to do treatment.
In some ways, there's the other side of it too, which is the people that screen positive for sleep apnea because there's these mass screening operations underway. We have a lot of signal that, the older that we get, the more this central hypopnea phenotype starts to blossom. And that doesn't seem to have as many health risks and things like that. So if people screen positive and their 4% obstructive AHI is reasonably low, this can help them sort of understand maybe, we can't use risk as a browbeating tool to make someone go on therapy. You know what I mean? Right. We never want to use the concept of a threat of the boogeyman incorrectly as a motivational tool. That just doesn't feel right. Here's another fun way to think about the risk. When I talk to my patients, I usually tell them stories, and I say, when you have obstructive sleep apnea, it's a little bit like having an evil nurse that only visits you when you're sleeping. And every time you have a blocked airway event, the evil nurse kind of shows up for a house call and gives you a shot of adrenaline, right? It's weird to think about, but when you're choking, that produces a physiologic response. It's very much like getting a little EpiPen injection. And so if that's happening all night long, again and again and again, the evil nurse is jabbing you with the juice over and over again, fight or flight gets jangled, what's going to happen in the morning? You might just feel like you just fell off a cement truck. And the point here is that sometimes the perception is just frequent awakenings and the sensation of just daytime blah. And talking to a person about like breathing may seem like a weird thing because they're like, no, I just don't sleep well. That they're experiencing what they experience. They may not connect it to the breathing. Any comments on this story, Steve?
No, this is the part where we have to help people understand that, look, it's not just about how you breathe, but it's about how you sleep. It's the quality of your sleep, not the length, not the breathing part. It's the total quality here. That's what explains your brain's ability to manage the next day.
All right, I'm gonna have to speed up this last bit. So our friend Kate is here to talk about risk. That's the first reason to treat. So what do we say about that? Well, her CMS AHI was only 4. So there's where she is. And so we really can't tell her, oh my gosh, this is the kind of sleep apnea that gives you a stroke. That's not really a reason to treat. When we talk to Kate about snoring, this isn't uncommon. She sleeps alone, so she doesn't know. But she does say, I do wake up stuffy and congested with a dry mouth. And so when we collect data, these snoring agnostics, we can sometimes find stuff with information. The Snore Lab app is something that you can download on your phone, and it can capture heavy snoring. The point here is that snoring is not just a nuisance, it's vibrational trauma. It's part of the way this disease gets worse. When you rattle those tissues around, there is neuromuscular damage in the long run. Steve?
That's right. Yeah. And SnoreLab I like the free version's fine because it limits how many times they measure. The paid version, they can measure every night and they get all worried about it.
Nice. Yeah, nice. Sleep experience, third reason to treat. So when we ask Kate, how was your sleep? How was that experience? She experiences it as light stage, poor quality. She has morning headaches, jaw soreness, 1 to 3 awakenings. Sometimes they're prolonged. So the sleep experience is a problem. How about the wake experience, Kate? Well, she has non-restorative sleep. Well, I don't survive without coffee. If you screened her with an Epworth score, it would have told you not to worry about it. But the Epworth score is not perfect, right? It just tells you about the propensity to doze. So she's taking Adderall for her ADHD symptoms. Is that really ADHD? Who knows, right? But she's just not experiencing her wake very, very well.
And many dentists, sorry, Dave, many dentists would have seen that achy jaws and some headaches and said, oh, you need a night guard.
Yep, that's right. That's right.
And because that's what they're trained in dental school to do, is to help people with those problems. And they can help them with those problems with that. But we have to be careful to ask a few more questions, dig a little deeper.
Yeah, I'm teaching my medical clinicians on this side now that if you hear about teeth grinding, you think sleep apnea until you prove it's not sleep apnea. Is that how you feel about it too?
Right. Yeah. The words you wrote down there that describe painful jaws, those need to be explored and ruled out sleep apnea before you make the next step.
For sure. Yeah, for sure. Flesh that out. Fifth reason to treat is the weight, the burden of all those afflictions that you carry, all the comorbidities. So she carries some. ADHD is what her label is, and she's been carrying that ever since she was in school and taking Adderall. Nocturnal bruxism with TMJ pain. I don't think it's a stretch to think that the Adderall could be pushing the bruxing. Do you, Steve?
No, not at all. It depends on when she takes it and all kinds of things like that. But the other thing is to keep in mind is Kate's only 26 years old. If she was 52 years old, the comorbidity list would probably be longer because the body's physiology would have been fighting this off for another 26 years.
Yeah, we can think about this as a chronic hyperarousal state. And our sympathetic nervous system is there to protect us. It's not there to sort of breathe down our neck. And when it does, the adult version of Kate, the middle-aged version, is someone who has migraines, someone who cannot sleep, so she has chronic insomnia and probably chronic anxiety and may maintain a lot of mental health diagnoses. Anything you would add to that, Steve?
No, I sit there with my 50-year-olds and think, okay, your body's been dealing with this for 45 years, 40 years, and no wonder your high blood pressure's up. No wonder you're having troubles. Yeah,
that's right. In the Impaired Sleep Apnea Project in the Bay of Narrative, we have haiku benches that make you stop and pause. So this one says, "Hear me, O system, I exist, I assure you, lo, my narrative." That's how important it is. It's our job to help the patient preserve the narrative because the fragmented system that we all inhabit is trying to turn their narrative into something treatable like a label. And we have to sort of help protect that narrative so the patient can make the right decision for them. So when we put this narrative out into the world, we're going to help her understand her narrative. Kate, this is what your narrative is. You have 6 out of 10 sleep satisfaction, points lost due to frequent awakenings, perception of light stage, poor quality sleep, loud but self-unperceived snoring with snoring aftermath symptoms of dry mouth and congestion, frequent morning headaches. She has a sense of brain fog without overt daytime sleep, excessive sleepiness spells, and the comorbidities potentially vulnerable to untreated sleep apnea include ADHD, bruxism, TMJ dysfunction, and headaches.
Several reasons of the 5.
Yeah, I think we could say we have several reasons to treat. So our coffee hut discussion, that's why we have a coffee hut, is it's supposed to be an unrushed, I imagine this liminal space where you have all the time in the world, and the Wurlitzer jukebox in the corner, and this really nice waitress that keeps bringing you pie. And you can sort of decide, are these reasons for me? And for risk, not really. We cannot browbeat her into say, this is going to kill you right now. As Steve said, this is a fluid disease that causes probably chronic stress, but it's harder for us to say, boy, you've got to go on a CPAP by gum because this is going to kill you. But the other 4 reasons, she's got them, right, Steve? Take it away.
Yeah, so see, look at that. Problematic. What a good word, because that indicates that there's actually a consequence in her life because of these things. And we can say, look, if we reverse these troubles, let's find out what happens. One of the things we have to be careful of is, oh, Kate, let me give you an appliance. Let me give you a CPAP. Make sure you don't sleep on your back. And all these problems will go away.
Right,
We don't get to say that. But what we do get to say is we have a potential treatment here, that we have several treatments that we can choose from to guide you to that will directly address some of the problems that are causing these issues for you.
That's right. That's right. And we have skin in the game for why are we doing this? And we're going to follow up. And if the thing we do doesn't resolve your problems, well, we've got tools for that. So the $64,000 question for Kate is, which interventions are most likely to soothe these reasons for her? Right? So that brings us back to our decision. Are we going to go from untreated territory over into treated territory? And what is going to be our mode of transport across that deep and turbulent river? And these are our choices. And we can sort of go through this with Kate one by one. Here's what we might expect from this. Here's what this might cost. Here's what you might be ready for in terms of your emotional readiness for interventions. And if we decide that all she wants to do is stay on her back and tape her mouth closed, great. We can follow up on those 5 reasons to treat and say, are we done yet? And if we're not, we can always move on. Anything to add to that?
No, we can start with non-invasive and simple and move on, to whatever she's ready for. In her case, she had an orthodontic treatment, so likely she's okay with her smile. She's okay with how her teeth look. So she's not in our office saying, I hate my crooked teeth. But what if she is? I mean, we have to know what she wants before we apply the treatments.
Absolutely.
And what is she ready for? I mean, she's 26 years old. Maybe she doesn't have a lot of money yet. Who knows?
Yeah, and is she ready for a CPAP? Maybe, maybe not. Maybe she's a scientist who's really interested in this expansive orthodontia narrative, and she knows that because she had this retractive, extractive orthodontia, maybe that might be something she could consider. So you really have to explore this with your patients, and the concept that your patient might have researched something already is something I kind of learned the culturally hard way, I guess, because here in Boulder, Ball Aerospace is just down the road. So it was very common for my patients to literally be rocket scientists. And they would come in with all kinds of knowledge, and you got to deal with that and help them find their way anyway, right, Steve?
And AI is really adding to that narrative quite a bit.
Oh, absolutely.
People come in and they've done the research, and I ask them, well, what do you know about these treatments so far? And that gives them an opportunity to tell me and ask questions.
For sure. So it's really about the right therapy for the right patient and choosing and following up. So we're going to co-discover our goals of therapy. And obviously, if we think risk is a goal of therapy, right, then we're going to have some objective way of saying, well, we did it. And that usually means some sort of objective testing. And this is where you would obviously be collaborating with your friendly neighborhood sleep medicine specialist, hopefully someone who shares this language with you. Snoring, our goal would be to eliminate that, right? Enough to allow co-sleeping, or for the snoring agnostic, to eliminate the snoring aftermath. For sleep, we tell them, look, we're trying to improve sleep depth, continuity, and duration. If this doesn't do this for you, then this isn't working to accomplish that goal. Maybe we need to think of something else. In terms of wakefulness, we say, look, we're trying to establish effortless wakefulness and improve concentration and executive function. And in terms of comorbidities, the ones we've identified and given labels to, we give them goals. Look, we're doing this because we are trying to make these morning headaches better, that TMJ, pain. We're trying to see if we can get those ADHD. Maybe you want to think about tapering that medication. Hey, did you know that Adderall might be making your clenching even worse? Interesting. Maybe if we do this can happen, and then this can happen. We're connecting those dots.
Very important. We work with our medical colleagues on issues like that one, because
for sure,
you're not going to be taking people off their antihypertensive.
Oh, no, I didn't want to give you the sense that was your job. But the idea that, hey, you might want to talk to your doc. I used to do this all the time. For somebody comes in on 4 different medications for their blood pressure, we find they've got big, bad apnea. I say, listen, when we treat your apnea, you're probably going to be able to come off of some of those meds. So if you start feeling like they're too strong, you call your doctor. Give them that sort of idea that this could happen, and it often does. Same thing for reflux medications, man. People be on those Prilosec for years because they have reflux. Just telling them, hey, when we go on this treatment, there's a good chance you might not need that. Keep that in mind.
One of the things I like thinking about too is the magic that happens around sleep, because dentists, you're not fixing their sleep. The brain fixes the sleep. What you do is you remove the barriers to sleep. You remove the irritants. And when you get that sorted out, then the brain returns itself to homeostasis. And I love that magic that happens there.
Boy, it is magic. So very quickly, summing up, our 5 reasons to treat paradigm, basically a collaborative sense-making tool that allows us to partner with our patients and take this to the next level, beyond the label, into the real reasons why we're doing this. When we're talking about the 5 reasons, the first step is risk. Yeah, I just call attention to the fact there's a lot to unpack when talking about risk, and it involves a nuanced understanding of that pesky metric known as the AHI. When we talk to each other, it's important to share a language, just as important that we share a language with our patient, that we talk to each other across silos with a shared language, so our patients don't get stranded in the middle. So we presented obstructive sleep apnea diagnostically, the ground truth as being captured in the ICSD-3 TR. So when we look at reports, we have to sort of compare those reports to the ground truth and see what might have been lost in translation. When we're using the term upper airway resistance syndrome, we're going to use it with a little bit of circumspection, knowing that we're capturing something, but that we say, well, we're calling it that here, but this is probably rear predominant sleep apnea if we were going to use the language of the ICSD-3. So we're translating for people so they don't get caught by that language.
What I say about that, because the patients don't understand upper airway resistance syndrome either. I say it's harder for your body to breathe through a smaller space.
Yes.
When you're trying to fill your lungs and it's pulling air through a smaller space, your brain has to be more active than it's supposed to be. And when your brain's more active when it's supposed to be resting during sleep, it's not going to feel ready to go for the next day. But you may not have a complete closure of your airway. You're just working extra hard. And that's by itself a problem.
It is a problem, and it's a problem 24/7. And I think that's why this term has legs in dental circles, is that there's been a lot more exploration about, the physiologic healthfulness of nasal breathing and effortless nasodiaphragmatic breathing. That's terminology that the airway-focused dentistry community is comfortable with. In the standard medical establishment community, we're still sort of learning that. And so this upper airway resistance syndrome concept, it has meaning, but we have to understand that it can also create a barrier, because it can seem like, oh no, you don't have sleep apnea because we're calling it this. I don't want that to happen. The point in this talk was that the personalized goals are co-discovered by the provider and patient. We don't tell the patient they need treatment. They tell us why they need treatment, and we co-discover it with them with the 5 reasons paradigm. And this structure serves as our, are we done yet? I tell my clinic ecosystem, this is our structure for why are we doing this, and is it working? We'll revisit this every single time.
And all of our treatment choices can be attached to those 5 reasons. So if we end up helping the patient choose a CPAP, for example, because it matches the 5 reasons that we've settled on between the 2 of us, that works. If we have something that, like in Kate's decision, she has these jaw problems. And so we choose an appliance that we want to help alleviate some of those. And if they have a nose breathing problem, we want to make sure there's an appliance that doesn't promote mouth breathing. And so we allow the lips to close in front of it, those kind of things. Yeah.
Yes. Personalized for their reasons and their moving parts. So bottom line, collaboration, which means collaborating in a way that the patient can engage with. Steve and I both talked about this, the word engagement. It's part of the process. It's not really collaboration if they don't have the agency and the understanding of the terminology involved. So that involves a shared language and a structure for unpacking that complexity that really deploys patient agency as a vital tool. The right tools. So understanding what the salad bar looks like and explaining it to your patients so that they can feel comfortable that they're not being just sort of shoved the only option that you know about. And then finally, that all equals adherence to therapy, because the patient chose it. That's why it's better adherence. And they know why they're doing it. So the outcomes, they're going to know what they're getting from it. So the outcomes are better. And this just helps workflows and practice growth, because people are going to know you're doing it right.
Yeah. Well, I'm sorry, go back one day.
Yes, sir.
Yeah. And so a few things about this. Collaboration also means between healthcare providers, which
That's
means
right.
if you get now some cases are simple. You get a report of a sleep test and a pre-encounter notes, the post-encounter notes, and you can get a pretty good picture of your patient's medical condition from from the provider of the sleep test. Others are much more complex, and you don't know which ones are going to come across the record sharing. And so I urge you to read through those. And if you find items in those encounter notes that you don't understand, well, that's an area of growth for you. And that's collaboration. If you need to call the physician, that's difficult sometimes, but after a while, they'll take your call. After a while, they get to know that reasons why you're calling isn't about getting more patients. It's about understanding the one that's coming up next Tuesday. And so that collaboration there with other healthcare providers is critical. If you're going to send somebody for expansive orthodontics, for example, you better know that orthodontist is on the same page for this importance of structure. Patient engagement is what we've talked about getting people to talk to each other. And then the right tools. If you don't know what Inspire does as a hypoglossal nerve stimulator, find out. If you don't know how a CPAP actually works, or what is a bilevel, and what's an ASV? I mean, that's not a college in Arizona. So what should we do? How does that work? And then if you ask your healthcare providers, say, would you please explain to me why BiPAP works? Then you get a chance to have a conversation, and then engagement with your other partners in healthcare might mean something. If they don't understand oral appliances, and chances are good they don't understand oral appliances, you can get an example out of a high quality device and say, okay, here's all the features that we can use here. Now, you don't want them to feel like they need to specify which device. As much as I love, Avance, for example, then I can't make Avance for everybody, so I don't really want the doctors to tell me to make an Avant. I want them to say make an oral appliance and I get to choose. But when we work all the way together that way, then we honor each other's contributions to that patient's health, including the patient's contribution to that patient's health. That's adherence to therapy.
Yep. And we've agreed on what are we trying to achieve here. And I like to call attention to the fact we're not trying to get the patient compliant on CPAP, for goodness sakes. We're trying to help the patient find their way to a better healthful outcome, really trying to reestablish functionally healthy breathing day and night if we can. Yeah. So I'll go to our thank you slide. This is one of my cartoons. This one is appears in a past issue of Sleep Review magazine. Just the idea that the more we look, the more we're going to see that sleep apnea is everywhere. So if the patient comes in, no matter what they look like, I suppose it could be sleep apnea, right? Because it could be. So we got to know how to unpack it. Yeah. I guess, do we have time for questions, or have we overstayed our welcome?
No, we do. Thank you, Dr. McCarty and Dr. Carstensen. There are some questions coming in, but before I get to those, I'd like to remind everybody to use the question and answer feature in the control panel on your screen to ask any questions that you might have. First question, either one of you, when should I bring up the 5 reasons to treat with my patients?
Well, if they come in to see me and we're exploring the possibility of sleep apnea, then I say, have you had a diagnosis? And if they have had a diagnosis, then I don't really want to talk to them too much until I've seen some of that paperwork, because I need to correlate with the 5 reasons to treat. And when they sit there and they say, oh yeah, I can't use my CPAP, and then I want to know, well, what got you in the first place? And so I start to assess things like daytime, sleep time, wakefulness, the other reasons. If I'm doing a medical history and I think see a bunch of comorbidities that are highly associated, like hypertension, for example, then I'll say, tell me about sleep. So it's all in a related way of organizing my thoughts. That improves the workflow because it keeps me from rambling on. I can hit some areas of focus.
That's great, Steve. I think that's a great answer. And all I would add to it is this is a yes and, is that the 5 reasons to treat is kind of like a surgical timeout, where you're like, okay, which leg are we sawing off? Everyone, let's check. It's going to be the left leg, right? There's reasons for that. They do that. It seems comical, but the wrong leg has been sawed off too many times because, we get into a rhythm. And so you see sleep apnea and you're like, so this is a timeout. Why are we doing this? Right? It's a way of saying, in the process, before we offer any treatment for sleep apnea, we are going to establish with the patient what their individual reasons to treat are and make sure they're comfortable with those reasons. And then we can explore, what do we have that might address these reasons? Does that jive with your experience?
Yeah, and also thinking about the standard dental, a common, let's say, dental response to my jaw hurts is, night guard. Mm-hmm. If you have this 5 reasons to treat in the back of your head, you think, oh, wait a minute, I better ask another couple of questions.
Yeah, because we might be dealing with a larger animal than that thing called TMD, right? That we all learned about in school, which is a simple thing that you just make a night guard for, whatever. No, it's bigger than that, right? And sleep apnea is bigger than just a CPAP machine. It's bigger than that now.
Or if they sit and say, I don't like my crooked teeth, or I look in there, I see a jaw structure I don't like. I need to think more about whole body physiology than I do just how the teeth look or how they come together.
Yes.
And because, like I tell my orthodontic colleagues, fantastic, let's get a great smile, let's get a good bite, let's make sure the jaw joints work, and let's make sure they can breathe well.
Yes, let's make them pretty and functional. Yeah. That's exactly right.
Okay, our next question is, if I don't have a scanner, can I still treat sleep breathing problems?
Oh, this gets to the how do I send the patient's data to a sleep manufacturer? All the manufacturers accept impressions. Most of them now really prefer scanners, and so the increasing level of detail we get in the high precision devices that we can make take away some of the problems that come along with oral appliance therapy. And we didn't have time to talk about those, but people don't need to worry about their teeth moving anymore because the devices that we get made from digital processes fit so well.
Okay. Next one, the dentists in my study club say I'm violating my scope of practice by treating sleep apnea. What can I say to them?
Dave, say more about that.
That's a tough one. If sleep apnea, in my belief, is too big for one silo. So a sleep medicine dentistry practice that is advertising as doing the diagnostics and treatment, we offer a full, by themselves. I think that might be a little cowboyish. I'd like to see that practice, combined with or collaborating with, holding hands with the medical side, so that the patient has all of the options that are available. I think that that about sums up how I feel about that.
Yeah, and from our side of things, it's the appliance doesn't fix everything. I mean, so we can't just do an appliance for everybody that says I snore. And
Mhm.
that's a real common question for me when I'm lecturing is, well, if they just snore, can I make an appliance? Of course, the answer has to be, how do you know they're just snoring? Snoring is
Right,
only
right.
one of the 5 reasons to treat. And so
Mhm.
yeah, snoring is a reason, but what if they have another problem? And how do you not know that they don't have another problem? If you have a bottle of antihypertensive pills in your dental office, you don't just hand it out if their blood pressure is too high that day. You got to
That's
you
right.
get the proper diagnosis. You got to move upstream, figure out where the problem is, and then apply the proper treatment for that patient. Yeah.
And I'm thinking that just comes back to the concept that let's talk about it. This discussion about risk isn't easy. That's why I drew that cartoon, that weird cartoon that says it's a ludicrous concept in some ways, but are you prepared to manage that risk going forward longitudinally by yourself? That's the question. Do you know what the risk is, and are you prepared to manage it? And the answer is you're probably not. We probably should shoulder this burden with our medical colleagues. I'm speaking for the dental community now, but you probably shouldn't shoulder that burden all by yourself. You should have someone help you.
That's right. And the physicians that I work with are happy to have me doing oral appliances because they
Hmm.
trust me for that part. They also know I'm happy to have them managing the CPAPs and the other things that go along with that medical issue because we're all in it together for the patient's best interest. And that's
That's
where
it.
we have to keep that in mind. I know we do want to streamline workflows and we do want to increase practice growth, but that doesn't mean we have to not be good doctors.
Couldn't have said it better. I won't even add.
Okay, next question. Sleep doctors send me referrals, but sometimes all I get is a prescription and the AHI score. Is that enough for me to treat the patient?
Not for
I,
me.
I would say that is an inadequate data set, and that's treating the dental office like a vending machine. And I think it's time to move beyond that. So what I would like to see in that referral, what I would send you, Steve, would be the patient's narrative and what I know about them, and anything that I think might help you in your decision making, such as the orthodontic history and the fact that her jaw's hurt. And then over to you, and
Yeah.
it should be from that point, I'm handing the baton over to another professional with the same language, and then you can sort of decide what is the best anatomic option for her.
Because oftentimes, if a patient has a complaint and they go and sit with their physician and they say, okay, here's my problem, the physician writes a good encounter note about those problems and then follows through on the process for a review of systems and does it proper testing and gives me all that information. Well, in that whole workup, the patient may have thought of some other issues. And so when I sit down and go through the history, it's not to repeat the same things that I already know because I read through those encounter notes, is to allow the patient freedom to expand on other things that might have occurred to them.
Mhm.
And the more complete the picture, the better off I'm going to be able to assess where we are in the game and apply the right kind of knowledge base, the right kind of support, the right kind of questions to allow that story to fully come out. And that gives us the opportunity to engage that patient at whatever level is appropriate for them and have them be confident of their choice going forward, which makes it more likely that they'll be successful.
That's the ticket. Patient agency and the decision is the ticket to success. And patient agency means that they're empowered, which means that they understand the complexity, which is where all the zaniness comes in and why it's so helpful.
And if I send a note back to the physician saying, please send me the encounter notes, the sleep study and the prescription is not enough, then I'm declaring where I am in that continuum of medical care.
Hmm.
Honestly, I'm
Hmm.
not a vending machine. I don't want
Hmm.
to just, insert your sleep study and your money here and out pops an oral appliance. That's not how
Right.
it works.
Well, and it won't be successful, and that's
Right.
why it shouldn't work that way. And I guess this brings us back around full circle to this idea of should we be selling these oral appliances direct to consumers? Is that the right thing to do? And I think we're getting to the point where we can see why this is a complex journey for both provider and patient to know if this is the right thing.
A lot of my patients, well, quite a few of my patients have tried an over-the-counter device. They've ordered something from Amazon, and
Hmm.
I love it when they do that because they come in, kind of thinking this is going to work for me. That one didn't work, but a full-on custom one would work. And
Hmm.
so it gives me a chance to apply, my best care to them, and they have a positive attitude going into it. What I worry about the semi ones, like the direct-to-consumer devices, I worry that because the fits, they just can't be as good, and there's no history taking that means anything. They have a brief conversation online with some kind of healthcare provider, so it's not zero, but it's
Hmm.
also not what we can provide hands-on, face-to-face, ear to mouth, and thinking about what's going on in the encounter. That's
Right.
just that's the human big difference. Yeah.
We have
the
a
humanity
related
of it.
question. The related question is next. The sleep doctor told my patient that they didn't have sleep apnea because the 4% AHI was less than 5, but they have all the signs and symptoms that something is really wrong. What do I say about this?
Yeah, so this is the perfect example of the division of language. So, you know, I hope going through that, understanding our ground truth is the ICSD-3, that a 4% AHI of less than 5 does not mean they don't have sleep apnea. It means that they're not going to get their sleep apnea paid for
Right.
by their insurance.
Or that one night test that they were allowed to have wasn't accurate that night. We know 20% of one night tests are suspect to some level. And
Oh yeah, there's going to be night to night variability. Yeah, for sure. Yeah, this is a fluid disease based on posture, position, the stuffiness of your nose, how much you drank last night. You know, there's a lot going into this.
yeah, so we have to guide our patients into their choices, depending on how much effort the diagnosing facility put into helping them understand what that one night test showed. We may be able to support them in asking for another test night, for example.
All right. Well, thank you everyone for your questions and for those wonderful answers. But we've run out of time today. If we did not get to your question, we will answer it after the webinar via email. Within 1 hour, we will send you a link to the replay of this presentation and instructions on how to access the CE quiz. Please be sure to complete the free CE quiz associated with this webinar to receive your continuing education credit. Thank you so much to Dr. David E. McCarty and Dr. Steve Carstensen for that amazing webinar, and for our sponsor for the webinar, SomnoMed. Thank you all, and stay safe out there.